You're listening to Addiction Medicine Beyond the Abstract, the official podcast of the Journal of Addiction Medicine. If this is your first time listening, thanks for coming. Addiction Medicine Beyond the Abstract is produced for your enjoyment and is focused on the latest journal-published research and science in the field of addiction medicine. Remember to add us to your favorites on iTunes, and you can also follow us on Twitter at ASAM.org and Facebook. Now let's go beyond the abstract.
Welcome to Addiction Medicine Beyond the Abstract. I'm your host, Dr. Sean McNeil. Today we're joined by two guests. They're both authors on a new article coming out in the Journal of Addiction Medicine entitled Characterization of a Young Adult Sample Accessing Buprenorphine via Telehealth in Philadelphia, Pennsylvania. I want to welcome to the podcast Margaret Lowenstein. She's an assistant professor in general internal medicine at the University of Pennsylvania Perelman School of Medicine. She's also research director at the Penn Center for Addiction Medicine and Policy. Also, I would like to welcome Jasmine Barnes. She is a master in public health, but is a PhD student in a joint doctoral program between San Diego State University and UC San Diego. She's also project manager at the Penn Center for Addiction Medicine and Policy. So, Dr. Lowenstein and Ms. Barnes, thank you so much for being guests on the podcast. I would like to give you both the opportunity to introduce yourselves to our listeners. So Ms. Barnes, if you could go first, go ahead and tell the audience a bit about yourself and about your background in the addiction space.
My name is Jasmine Barnes. I am currently a project manager at the Center for Addiction Medicine and Policy at UPenn. I'm also a PhD student studying substance use research at SDSU and UCSD, the Joint Doctoral Program in Public Health. Regardless of anything that I've done professionally, I always preface any conversation I'm having about my work with my lived experience. So I am someone with family lived experience. Both of my parents struggled with substance use growing up. And their journey, their struggles really motivated me to learn more about substance use and specifically the social, cultural, systemic drivers of substance use and specifically what those might be for people of color. So that's what got me interested in the field, and I've pretty much been able to, so fortunate to be able to do this work alongside amazing people at Penn Camp.
Well, thank you. And it's wonderful to have you. Dr. Lowenstein, would you go ahead and tell us about your background?
Sounds good. So I am an internal medicine and addiction medicine physician. And got actually very interested in this type of work during my internal medicine residency, where I took care of a lot of patients who had complications of their addiction, but we would kind of fix up the acute thing, and then I didn't really have a sort of a toolkit or see an approach for really fixing the underlying thing that patients were struggling, which was their substance use disorder. So I got some additional clinical training. I did some electives. I actually started doing some addiction work in my first job. But what then sort of fast forward, that's what brought me into the research world, was seeing that we had really effective care, but we were using it very, as much as we could be. And so I, kind of got interested in doing research. I did some training and have also been fortunate to get connected with this amazing team at Penn who's doing both kind of care delivery and studying it. That's how I get to work with Jasmine and, have been able to build a research program related to a lot of these themes alongside our amazing team.
All right. Well, welcome to you both. So we'll get into the first question, which is, I would like one of you to describe this Care Connect program and your roles within the program, and also how does this program seem to impact your patients?
Okay, so for Care Connect, in a nutshell, it is a virtual telemedicine bridge clinic. So at the core of our work, we focus on the substance use navigation. So specifically with this role, individuals are able to call into a phone line, which is available 7 days a week, 9 a.m. to 9 p.m. And if they are interested in starting buprenorphine, we are able to connect them with providers who prescribe. Everything is done over the phone. I think the heart of the program is not only getting people connected to care, but all of the work on the back end that we do to ensure that people are able to continue their care. And what that typically means is connecting them to resources to support their recovery. So for some people, that looks like connecting them to resources like transportation, anything you can think of for some that would be important for someone in early recovery as they're trying to reestablish their lives, or even for people who are just trying to continue because life happens to us all. So it's just resource connection, getting individuals connected to medication if that's what they want. And then aside from medication and resources, even if a person just wants to call in and learn what their options are, it is truly a safe place for people to land and learn more about how they can begin their recovery, regardless of what stage they're in. To give an idea of some of the situations we might run into on the Worm Line, I've supported quite a few patients over the years, and one in particular I can think of very early in my Worm Line days was a patient who was struggling post-breast cancer surgery and was started on pain medication, which was abruptly stopped, and had resorted to using pills that she would source from the street. Didn't know what they were, but was very clear that she was using opiates, really afraid about her risk for overdose, and wanted to begin treatment so that she could help continue to address her pain, but also not have to rely on medication that she was getting off the street. And so when I first met her, we talked a bit about what her journey has been like, really struggled with accepting that this was where she was, but really also interested in starting treatment. So we talked about medication. We talked about maybe a little bit of her ambivalence towards medication and not being ready to take that step. And I worked with her through that, and eventually she decided to start medication. We stayed in contact. We got her connected to care at Penn, and she was doing great. Last I spoke to her, she had been engaged in care for, I believe, at least a year and a half, and doing really, really great in her recovery. And in the midst of the time that we connected her to care, there had been multiple other resources that she needed. So it wasn't just the medication, as I described before, it's a safety net. So it was things like transportation. I remember she called for that, even just to talk about what her first appointment was like and how she didn't expect the doctors to be so kind to her, and really wanted to thank me, and not only me, but the rest of the team for the services that the Worm Line provides, just to give an idea of the type of support a person can receive if they call in.
Okay, great. Now, can you talk a little bit about the specific gaps that tend to affect adolescents and young adults and maybe other special populations? I know we talked about the incarcerated patients and those re-entering after incarceration, people that might lack insurance, racial and ethnic minorities, just to name a few.
Okay, great. Yeah, so I think the examples that Jasmine gave her is helpful, like illustration of some of the gaps that people face. But we know that, all groups, including adolescents and young adults, but really everybody has a lot of barriers to getting medication. There's sort of like high level things like, medications are often not available widely in different settings. People need to have insurance typically, or in most cases, in order to access it. Sometimes treatment settings themselves put a lot of burden or requirements on patients that aren't realistic or don't acknowledge some of the competing priorities in their life. Sometimes it's just things that seem really simple, like the examples Jasmine gave around like getting a ride, or, people don't have the money for their copay. So there's just like a lot of gaps or things that create roadblocks to treatment for all patients. That is, something that we try to address through Care Connect in a lot of ways. And then, for younger adolescents and younger adults specifically, I think we know that the systems or, the settings where they get care may be even less familiar or comfortable with medications than, kind of general adult settings. We also know that there's just sort of maybe more involvement from parents or peers that like sometimes is helpful, but sometimes can complicate things. Adolescents may not be as connected, or young adults may not be as connected to healthcare in general because they're generally otherwise pretty healthy. And then there may be some like particular stigma for this group. So I think, we know that, this is a group that in like many studies have had a harder time accessing treatment. And then there are like particular challenges to some of these special populations, and maybe I'll let Jasmine speak to that part.
Yeah, can you talk about that? I know specifically in this study there were some findings around racial ethnic minorities and issues with care access or care retention. So we know that those groups, in addition to individuals leaving incarceration, typically there's a lot of structural inequities that impact care access, including a lot of the things that Maggie actually mentioned already. But some of the things that we see is just like fewer treatment providers, lack of culturally appropriate care in certain areas, and just a longstanding mistrust of healthcare systems in general that I think really uniquely positions the warm line to not only fill those gaps, but to be pretty much like a first point of access for people. And I think one of the things that make the program so special and why it can reach these populations is that it's driven primarily by peers, and who often, because a lot of us on the team have lived experience, or our peers in recovery have have experience is what I meant, connecting people to care and getting them in care that makes sense for them, and that does include adolescents and young adults. Another thing I wanted to point out specifically with special populations, and I know that this is a kind of buzzing topic right now, but specifically for individuals leaving incarceration or navigating like other care transitions, continuity of care specifically during reentry is often pretty fragmented. And I think one of the things that, again, make the Warm Line so special is the fact that we've established these partnerships and have therefore been able to fill these gaps and really supporting special populations who, as Maggie mentioned, have really high needs. And it doesn't, it's not a poor reflection of them, but a poor reflection of like how the system often fails people. And then fortunately, we have programs like this that exist to kind of fill those gaps and support people where systems traditionally have not.
I will maybe add one more thing, which is that, one of the roles that we play in Care Connect, and I think other programs like this one play, is filling insurance gaps, which I mentioned briefly, but I think, we know that health insurance is like in this country often kind of one of the main keys to accessing treatment. Medicaid, for example, is the biggest payer of substance use treatment in America. But even if you're sort of eligible, there's lots of, you have to do paperwork, you have to confirm your eligibility. There's sometimes it gets turned off if you're incarcerated. There's a lot of, kind of complexity around insurance, and that is likely only to increase given the, policy changes that got put into recent federal legislation, the HR 1 or One Big Beautiful Bill. So, I think programs, we're going to see probably increased churn or fragmented insurance coverage. And so I think this is a really important role that programs like this play, but that still creates challenges. And, I'm sort of jumping ahead to one of our findings, but lack of insurance at the time of a call was one of the predictors of not linking to care. So I think this is, something that is worth calling attention to, because that's a big gap that is likely to get bigger.
All right, good. Now, would you like to highlight some of the results from your study, which seem the most impactful to you?
Yeah, so I think we looked at, in this study, we compared, younger adult callers, ages 18 to 29, to callers 30 and above. I'm not going to call them older adults because then I'm an older adult. So we compared kind of younger callers to other adult callers. And what we found, interestingly, was that when we saw younger callers were more likely to be incarcerated in the past month, was interesting, and to identify as Hispanic. But what we did not see was actually differences in our kind of ongoing retention in buprenorphine at 30 days by age. So we did see some lower retention for those who were younger and had identified as Black. And we also saw lower retention among those who were uninsured. So I think those are like the high-level findings. A couple of things that are notable to me. One is that among all callers, regardless of age, more than 3/4 of them were calling for a bridge prescription, which meant that they had buprenorphine within the last 2 weeks of the call. That's how we calculate or determine that it was a bridge. And I think that's really interesting because it just shows how kind of fragile and fragmented this care can be. Like, these are folks who were in treatment and for a variety of reasons, weren't able to continue to access their care even though they wanted to. And I think that speaks both to like the importance of programs like this that are a low barrier, that do get, prioritize rapid and consistent access to medication, and also, maybe shows some of the various holes in our system that exist, whether it's related to care transitions, insurance instability, just logistical challenges. There's a whole host of things. But I think just the fact that so many of our patients actually were in treatment very recently and called to continue to get access speaks to the importance of this program. The other thing I'll say is that, there's other data from other settings that show that adolescents and young adults are less likely to access medication or to get medication. And in our study, there was no difference by age in who was had retained in care at a month after their call, which I think maybe speaks to the value of models like this in creating access for or preserving access for younger adults and adolescents, and actually maybe not perpetuating that gap, and that maybe there's this is some demonstration of the feasibility of some of these telehealth models for kind of one-stop shopping for treatment. I think the ease of it, just calling a single number and being plugged into medication, to resources, to supports, all of that is really valuable and can help folks who don't quite know where to turn get resources. I'm going to let Jasmine fill in things that I may have missed.
I don't think I should add anything to that. I mean, I was going to talk about the bottom line about low barrier treatment being, so I guess for me, the impactful results, like the bottom line is that low barrier care and telehealth, low barrier care and telehealth-based models do help to close those gaps. And I think it really takes us a really long way in justifying how this improves accessibility and how these models can improve treatment engagement and kind of offset some of the negative impacts, social things, policy stuff, systemic stuff that keep people out of care. As Maggie said already, I think this is a perfect example of how the Warm Line acts as a safety net for individuals who are trying to stay in care. And I think I mentioned already, but really just helps to support people even in the absence of the resources that we know are really impactful in terms of care retention. So those are the things that we mentioned already, like insurance coverage, transitioning back to the community from incarceration, and even dealing with some of the higher level systemic things for racial and ethnic minority groups.
All right. So now you mentioned that you didn't see differences in retention between young and old in your program. So does this type of program help to fill some of the gaps? Is that what that means? And also, how do you interpret these findings?
I think it's very promising. And I think it's just a testament to the fact that when we do have the possibility for other care models like this one that's like really adaptable, scalable, flexible, really peer-driven. So there's a level of like relatability when you call into the Warm Line. Generally, people who use drugs have really hard time engaging with care systems for a lot of the reasons that we all may know already. So, and a lot of people have already tried so many times by the time they make it to us. So it's really important for this to, as I mentioned before, be a really soft place to land. So I think, as Maggie mentioned, there are some studies that talk about younger patients having lower retention in treatment, but I think when you bring in something that's super accessible and supportive like this care model, this is just a testament that we're moving in the right direction. And what happens when these programs do exist is that those differences can really start to diminish, and we can start to close some of those gaps. So I found that to be really exciting and promising. I don't know if Maggie has anything to add to that.
Yeah, no, I would echo what you said. And I mean, I do think this kind of pretty easy to access one-stop shop, and I think just really amplifying what Jasmine said about the kind of friendly and comforting nature of the team that really answers the phone here. It's all people that are really compassionate and committed to this care. I think that is probably the secret sauce that is, all part of this. One very small study, I don't know if we can say for sure that this is the way to solve all the gaps, in treatment for younger adults. But I think lessons learned from this model can really help inform models that are, continue to try to close these gaps. I would also, I guess, add, this maybe gets to some discussion that is further down, but I'd also add that, we as treatment systems for substance use disorder, often make it hard for patients to get care. There are a whole lot of navigation and logistical and other challenges, but really, instead of putting up roadblocks, we need to actually anticipate and plan for these types of hiccups, logistical hurdles, insurance, just complicated life circumstances or ongoing or return to substance use. All of those things are actually kind of things we should expect and be ready to address as providers of substance use treatment, not kind of viewing these as challenges or failures. And so I think that's another lesson that we can take from this program. And I think particularly for younger adults who may be less familiar with treatment or healthcare access or other things, having, the ease of access in a program that's sort of ready to navigate those pieces. Maybe that may be part of why we saw, no difference across age groups.
All right. Now, a study like this may have a way of uncovering additional gaps. Are there any new challenges that you identified that you might like to study further or that might need to be addressed in the future?
I think we could point to, there were some results that, or some kind of characteristics that were associated with lower retention among people who started calls. So maybe we can go talk about that. I know, the combination of younger age and Black race was associated with lower retention. Lack of insurance was also associated with lower retention. So I think those are both things that are not unique to us, but those are, whether it's kind of racial disparities or, insurance access being a main, lack of insurance being a barrier to treatment. I think those are, sort of well-described persistent challenges that, we as a team on Care Connect are trying to sort of work on, making sure that we're providing the best care to everybody to try to, overcoming the specific challenges to each of those situations. But I think that probably also speaks to some of the systemic and structural challenges that we have, and that are faced by people, minoritized racial groups or folks who are uninsured or can't access insurance. And, in addition to working in our own programs to try to help support those specific patients and situations, probably need to advocate for some larger structural supports and changes. Jasmine, I don't know if you have more to say about that.
No, I think that was great. I think that was great. I won't take us down the rabbit hole of advocating to reduce administrative barriers. I think you talked about a bit of that on your last, maybe the last question, but that's more around what gaps already we know are out there. The only thing that I'll add is that I think it would be really interesting to learn more about care trajectory specifically for young adults and what some of the administrative barriers might be. I know that there's also sometimes concerns around confidentiality and young adults possibly feeling a bit of stigma and really, I think not really unique to young adults, but like a lot of people, as I mentioned before, but just not really knowing where to start. And I think that it would be really important to learn more about what specifically motivates young adults to even seek treatment in the first place, and what administrative barriers exist. Because what we know so far is that the warm line has been really instrumental in things like reducing the time a person has to wait in order to get medication. We are able to see people same day and get them medication same day. They get connected all within one day, but sometimes connecting people to care in some areas, appointments could take a while, sometimes a week, sometimes 2 weeks. And in the absence of programs like this, people would just go without medication. Maggie talked a lot about expanding insurance coverage for treatment. That's also an area that's really important. And I think specifically around young adults, what I said about confidentiality and being able to kind of initiate this on their own and finding care that is specific to them is something I think is really interesting and could be a fruitful path for where we could go next in learning more about how to serve this population in particular.
Okay, great. Now, I'd like to end on this point, just to see if either of you have recommendations that might be useful to clinicians, irrespective of their locale. I know your paper focuses on Philadelphia, but just general advice for clinicians out there who might be listening.
If I had a chance to give advice or share anything I've learned with clinicians who are considering doing something like this, I would really advocate for low barrier care for many reasons, but I think the most practical reason is that it makes sense, and specifically models like this one. I think there's a couple of like really big lessons that come out of this work that really make this model unique, and it's something that I think is really instrumental to our success. If I'm being honest, so the first thing is that we intentionally involve people with lived experience. As I mentioned earlier on the call, this is something that's driven by peers. Our director of our center is a wonderful, amazing peer who really started all of this and really opened the door for a lot of us to come in and share our lived experience and really do work that's meaningful and impactful. So we intentionally involve people with lived experience in program design and implementation, so actually doing the work ourselves and supporting people in real time. So I think overall it's worthwhile to consider that treatment engagement fluctuate over time. And when we talk about low barrier care and access being really critical for these populations, this is really at the heart of what harm reduction is. And it's, as we all say, we love saying this phrase, but it's wonderful. It's meeting people where they are and at whatever phase or stage, or I don't know how else you want to frame it here, but wherever they are in their process. In real time, this looks like the reality of life for someone in recovery by removing really unnecessary hurdles and allowing people to enter treatment when they're ready. I don't think we talked about this much in the call, but a huge part of what we do is if somebody says they're not ready, our team has done amazing work to help people to learn how to test their drugs. And we've done tons of community work around overdose prevention and lots of other things. So I think for clinicians, for me, the big message would be really getting plugged in and learning about how to make care more accessible, more practical. And I think kind of like disconnecting it from historically, I think what it's been for a lot of people who are entering care systems, it feels like for a lot of people, it's just been really far off at a distance, something they can't reach, they don't have the support, and really making it something that's in reach and accessible, and really removing all the, as I mentioned before, all the unnecessary burdens that make it really hard for people when, as we're demonstrating, it doesn't have to be. You know, it doesn't have to be something that's so it is complex. I don't want to take away the complexity of it all, but I think one of the things that really attracted me to the work itself was I was like, man, this is easy. Like, not easy, right, because it's hard, but it's easy in terms of, like, getting people in care. I mean, I don't want to say you snap your finger because it's not that simple, but it happens really fast in comparison to what it would be without it. So, yeah, get plugged in, learn about how to replicate these kinds of models if it's possible where you are, and I'll end on just, like, reaching out to Maggie or Dr. Perrone or other leaders in the field who are doing the work already. And I mean, maybe in that case, a clinician would become a student again, but I think that is a wonderful approach, and really one that I think really shows, like, the heart of the person who's behind, like, you know, the stethoscope, and like, you're a doctor, yes, but you're a human first. So I'm going to stop there because I feel like I'm rambling, but yeah, that's what I would say to somebody who's like, I want to learn more about what you do, and I want to see if I can do it too.
I'll say, you know, I think in our case, we started our particular program during COVID, where we were seeing a lot of folks who were, you know, falling out of care or struggling, but also, you know, some new opportunities with regulatory changes to kind of, like, use telehealth in a more, you know, in a larger way to help address this. And we started very small. We had, you know, a couple of peers, really one lead peer who's been kind of the force behind a lot of this, and a few clinicians doing this on the side. And what we were able to do was, you know, just started and then found some great partners. In our case, we had a telehealth urgent care that we partnered with to do some of the prescribing. We got some funding from our local city government and other entities, but and some of those are specific to us. But I would say, like, really, like, the driving force in this is a lot of what Jasmine said. It's like we have peers and folks who live experience really front and center. We want to make this a comfortable and accessible place for people to call. We've, you know, been oriented towards problem solving, and really the kind of guiding light is, like, maintaining access and overcoming barriers, and then have been able to grow by finding partners who sort of, within our local context, who've wanted to go on that journey with us, and, you know, have been able to expand quite a lot since we started. So I think, you know, as clinicians trying to do this, I really think, you know, like Jasmine said, don't be afraid to kind of lean into, you know, just, like, doing, like, what you think is going to, you know, or lean into the fact that, like, we want to treat patients with humanity, with autonomy, and we want to help them overcome their barriers, and then finding partners that are sort of, you know, aligned with that has been, I think, a really important part of the work that we've done.
All right, well, I want to thank both of our guests one more time, Dr. Lowenstein and Ms. Barnes, for being guests on the podcast. Again, their article is titled Characterization of a Young Adult Sample, Accessing Buprenorphine via Telehealth in Philadelphia, Pennsylvania. Their article can be found in the Journal of Addiction Medicine. Thank you for listening.
This ends today's podcast. Thank you for listening to Addiction Medicine Beyond the Abstract. All of today's show links can be found in the show notes. And remember, you can preview additional abstracts at journaladdictionmedicine.com. This program was produced by the American Society of Addiction Medicine.